Welcome to this week's edition of the TIROxMDS multidisciplinary seminars. As is our custom, this time of the day and wherever you are in the world will be our tumor board this morning. We've got three excellent cases brought to us from China, just amazing cases from Dr. Guan, who'll introduce herself here in a minute. I'll go to the next slide and have our panelists introduce themselves as usual. I'm Mike Tuttle. I'm one of the endocrinologists at Memorial Sloan Kettering Cancer Center. And my job is to try to keep Dr. Ghesani and Dr. Urken under control for the next 59 minutes, and we'll see how that works out. Let's just go around the top here. Dr. Busaidy.
Hi, I'm Naifa Busaidy. I'm one of the oncologic endocrinologists at MD Anderson Cancer Center.
Awesome. Dr. Urken.
Yeah, good morning and welcome to everybody. Mark Urken, I'm a head and neck surgeon here in New York at Mount Sinai.
And Dr. Khorsandi. Oh, unmute. Azita. There we go.
Azita Khorsandi, radiologist at Mount Sinai.
Dr. Baloch.
Zubair Baloch, pathologist at University of Pennsylvania Medical Center in Philadelphia.
Fantastic. Dr. Iniguez-Ariza.
Yes, I'm in Mexico City. I'm an endocrinologist that mainly see thyroid cancer.
Fantastic, Nicole. Thanks for joining us this morning. And from somewhere in the Middle East, Dr. Ghesani.
Hi, Munir Ghesani. I'm one of the faculty members in radiology and neurosurgery at Mount Sinai and Chief Medical Officer of United Diagnostics. Good morning, everyone.
Fantastic. And Dr. Guan, introduce yourself and where you're from, and then we'll start on the cases.
Okay. Hi, everyone. Good morning. I'm Haixia Guan. I'm from China. Now I'm working at Guangdong Provincial People's Hospital. I'm an endocrinologist. So today I'm going to present three cases with differentiated thyroid cancer. So very pleasure to be here.
Very good. All right, Jacob, let's take.
Can I share?
Yep, there we go.
Yeah. Okay. Today I'm going to present these three cases. So let's start with the first case. I do not have anything to disclose. So the first case is a middle-aged female patient. She went to the thyroid surgery department in 2017. At that time, she was 50 years old. And she complained about a mass on the neck for over 20 years, with significant enlargement for the past 6 months. So back to 1990s, multiple thyroid nodules were found on physical examinations. The patient was advised that the nodule were likely benign during the follow-up. And the nodule in the right lobe gradually increased in size and grew faster in 2017. So she was admitted to the surgery. So here is a history of her disease, and she was 57 kilograms, no significant family history, personal history of past medical history, and physical examination showed a 6 centimeter firm nodule on the right neck and 2 centimeter firm nodule on the left. Both nodules had smooth surface. So this was her third ultrasound in April 2015. That was 2 years before she came to the hospital. And at that time, the right nodule was 3.2 by 1.8 centimeter in size.
Okay.
And this was the...
Okay, go backwards.
Okay.
Let me bring Dr. Khorsandi in here and just sort of talk through the radiology for me here, Azita.
So, we use the TIRO classification, and so it's a solid tumor. So it's 2 points, it's echogenic, it's another 2 points. But what I don't like about, and it's wider than taller, which is okay. What I don't like about this, that makes this, it makes it a higher grade that at this point, I would have called it a TR5 because of 7 points, is that irregular medial border. That, we've all seen lots of thyroid nodules. But when you think about it, none of them have that nodularity along their border. They're generally well defined. That, to me, it's always a red flag.
Okay, next slide. Keep going, Dr. Khorsandi. We'll go next slide there, Dr. Guan. Dr. Ghesani?
The next slide was 2 years.
Yeah, hold on, Dr. Guan. Let me just let Azita talk through these. Azita, what are you seeing here?
So the lesion has significantly enlarged. It has areas of hypoechogenicity in its center and some vascularity. And, on these slides, I don't, again, see the entirety of the mass, but the lesion has probably, it's double the size. And again, I think the medial border is irregular. And the issue is once it gets this size, where do you do the biopsy?
Yeah. And let's look at the CT scan. Help me with the CT scan here, Azita.
So the CT scan they did with and without, which we don't really need to do that without because of the extra radiation. But the things that we look at when we do CT for thyroid is invasion, tracheal invasion. And we're not very good at it because generally everybody expects to see nodularity with invasion. And we don't when it goes to the perichondrium. It's really, I have a very hard time talking about tracheal invasion. And sometimes, a lot of times, most radiologists, we don't talk about it. The surgeon gets in there and they get angry. We can talk about vocal cord paralysis, which is something the surgeons can see or cannot see. And if a lesion is enlarged, the other thing I like to talk about, if it's substernal extension or not. On these, we also can talk about lymph nodes, particularly the biggest reason we do the CTs is on ultrasound, we will miss the lateral retropharyngeal lymph nodes.
And Dr. Urken, what are you thinking about this? You see this CT scan. What are you sort of thinking from your surgical aspects and that kind of stuff, Mark?
Yeah, so I agree with everything that Azita has said. From my perspective, nothing about this looks terribly concerning. The proximity to the carotid is that area is well preserved in terms of a plane, and there's nothing that looks terribly ominous. The only and certainly the interface with the esophagus looks fine. The only thing we can't tell really is what's happening at the interface with the wall of the trachea.
Now, Mark, does the fact, I mean, I thought we were going down the pathway of multinodular goiter, but this looks like big nodules on one side and not much on the other side. Is that still multinodular goiter, or does it make you think differently?
Well, I mean, from the point of view is, yes, it appears that there is certainly nodularity on the opposite side here, but this mass has changed so significantly in size. One certainly is worried about what the underlying biology is. So I'm not sure whether it makes a difference whether we're dealing with multinodular or not, but this change in size is certainly concerning.
All right, Azita, let's show you one x-ray and then we'll pick up the case again. Next slide.
So the x-ray, the biggest takeaway from this x-ray was the significant tracheal deviation. You see the airways deviated to the other side. So you just basically see a mass. It's difficult, honestly, in this setting to talk about lung nodules. The image is not big enough, but it's interpreted as having multiple lung nodules.
All right, back to you, Dr. Guan. Where did we go from here?
Okay, that's all before the surgery. So before the surgery, we also taxed the cell function. So her cell function was normal at that time, and troponin, serum calcium are all normal, and vitamin D is okay, and liver function, T-spot, TB test, and the hepatitis viral panel are all normal. So in December 2017. She was performed a total thyroidectomy. So during the operation, surgeons found that her right thyroid lobe was entirely occupied by a big nodule measuring about 8 centimeters in its longest diameter, and significant inflammatory and adhesion was present in this area, involving both the strap muscle and the critical thyroid muscle. And intraoperative frozen section pathology showed this is a typical adenoma suspicious for capsular invasion malignancy to be ruled out. And here is her post-operative pathology slides.
Dr. Baloch, you want to sort of walk us through what you see on these, Zubair?
So thank you. Good pictures. So what I want to point out is on the bottom left of the slide, what you see is that dark blue. That's the neoplasm, and it's dark blue always means that there's a lot of DNA in those tumor cells. And it is what you can see is like small islands of tumors and large islands of tumor. And that looks like more of an infiltrative process. Even on low power, looking at that infiltrative process, it looks like carcinomas. Benign nodules do not do that. Now, on the right hand, bottom right, you see one large space where the arrow is, and next to it is another smaller space. And that, to me, from that power, looks like a blood vessel. Actually, it's a larger blood vessel, and there is a tumor deposit in that. And you can actually even imagine that almost is the edge of the specimen. And sometimes when you have such a cellular tumors, you are grossing it, there's always a problem that sometimes tumor just manually can float into the blood vessels. But if you notice that big space, the tumor is attached to the wall of the vessel. So this is actually very true for a big vessel. So that will be angio invasion, not lymphatic invasion. And you can see a smaller space just beneath that. That's where also the tumor is sitting. So I will be, for me, the low power, and there's very little amount of thyroid tissue left. You see two small follicles sitting right at the edge of it. So this is an infiltrative tumor. It's so dark at this point that I have to make sure that I'm not dealing with a high-grade follicular-derived carcinoma or a tumor which has undergone poorly differentiated transformation.
Fantastic. And I think we got a close-up, a higher power view of that, Dr. Guan. Zubair?
Yes. Yes. So you can see that beautifully here on the left side, which is the one panel figure. You can see two compressed follicles, benign looking. So that's the edge of the slide. You can see the blood vessel where there's tumor thrombus, which is attached to the wall. There's a smaller vessel. So maybe this is a one vessel, but I think these are probably two vessels or tumor kind of creeping like a snake-like fashion into these blood vessels, and definitely an infiltrating process. And what you can see on the top right, there's a thyroid tissue and the tumor islands are infiltrating into it. So this is definitely infiltrative. It's really dark. So I really have to make sure that, and I bet that this is going to act very aggressively and it'll be classified as a high-grade follicular-derived carcinoma. Does not look like anaplastic at this point.
Gotcha. All right, Dr. Guan, how did your team read this?
And so the pathology actually was now done in my hospital. So it's in the local hospital. So the local hospital reported, the right lobe is a follicular cell carcinoma with capsular and lymphovascular invasion. So this is follicular thyroid carcinoma.
And Zubair,
And the left lobe.
Yeah, just remind me, Zubair. So this looks like a RAS-driven follicular thyroid cancer. When you're thinking about its high grade, what are the features you're going to look for? Just to remind us again.
So what we have realized that depending upon the architecture, before 2022, one of that middle intermediate risk category that we had was poorly differentiated carcinoma, which had solid growth pattern. What we have realized now that the two most important pathologic variables that looking at that this tumor is kind of crossed over from your regular papillary or follicular is necrosis and mitosis. And it's or. Most tumors show both. So when you have necrosis of the tumor, that means the tumor is high grade, or either mitosis, which can be 3 or 4 mitosis per 2 millimeters square of the tumor. In this tumor, the tumor has a lot of lining, like a lot of cells kind of lining up. So to me, this more looks like a poorly differentiated carcinoma. And I think likely it was arising from a papillary thyroid carcinoma. But regardless, this is looks like a follicular-derived high-grade carcinoma.
Awesome, fantastic. All right, Dr. Guan, so what happened to the case? Postoperatively, where did we go?
Actually, I want to add here because after that, we kind of do the gene testing for this patient. And this tumor turns out to be a RAS mutation plus EIF1AX mutation. So it turns out a high, aggressive type. Okay, I will move to post-operative follow-up. So,
just ask one quick question for Zubair. Zubair, what do you make of the surgeon's perception that there was this inflammatory process around this tumor? And 1 week ago, we had Dr. Ito from Japan on, and he made it very clear that it's the surgeon's perception of extrathyroidal extension that takes precedence over whatever the pathologist sees under the microscope. But do you have any thoughts about that?
I personally think that I think it's a combined effort. So I really pay attention to when the surgical note shows that there was this inflammatory response. And I'm not seeing any kind of inflammation or chronic lymphocytic thyroiditis in that gland. And what I'm showing that this tumor is infiltrating into parathyroidal soft tissues as well as the skeletal muscle. I always pick up a phone and call the surgical team and saying, when you were, what did you meant by this inflammatory response, right? Did you see really like this whitish kind of tumor infiltrating and this stuff? So I personally think that sometimes it comes to like what the surgeon sees in the operating room is like, I know it's a definite, but to me, it has to be combined with the pathology. So that conversation, I think, is very important for me personally to decide whether this tumor is going to be a T3B disease or not. I mean, if it's massively involving the skeletal muscle, which is not within the thyroid, but outside the thyroid, I mean, it has to be correlated what you see in the operative room. So personally, I think it has to be a combined effort, before I click that off. Right.
Okay, Dr. Guan.
Okay, so the follow-up CT scan on 2 months after thyroidectomy, the CT scan found probably there is a lung metastasis, and neck ultrasound and the thyroid imaging show some residual thyroid tissue. And this patient received radioiodine in 2018. Before that, we noticed that even though we kind of put LT4 on this patient, her TSH kept at a high level over 20 and her TG over 300. So after radioiodine treatment, here is her post-therapy whole body scan. We found the residual thyroid tissue and bilateral lung metastasis in this whole body scan.
All right, let me bring Dr. Ghesani.
Here,
go back one for me there, Guan. We're doing good. Let me bring Dr. Ghesani in there. What are we thinking here, Munir, looking at these scans?
Yeah, so this is clearly an expression of iodine avidity because you can see extensive lung uptake. Typically, when we correlate that with the CT scans, oftentimes we see miliary pattern of uptake. I wonder in this case, the actual administered activity of I-131 could have been higher given the lung metastases. We typically, if we know already up front de novo there are lung nodules, we perform the dosimetry as well and try to go higher dose as long as the lung tolerance of 30 gray or lower is ascertained. This is a younger patient, so I think overall a dosimetry guided approach could allow us to deliver higher administered activity than 100.
And let me bring Nicole in here. Nicole, in Mexico, for this patient, young lady, she's got a RAS-driven tumor. She knows she's got lung metastasis. How do you prepare her for radioactive iodine? What's your usual administered activity?
We would usually do withdrawal, stop levothyroxine, and then give for this we would probably start with 150 millicuries.
Yeah, to go with that. Okay, so she responded, and then where did we go from there, Dr. Guan?
okay, now her diagnosis right now is a follicular thyroid carcinoma according to the HECC. Now she's stage 4, but of course this is a ATA high risk thyroid cancer. And after radioiodine treatment, she was put on LT4 again. However, though her body weight was stable at around 57 kilograms, and the LT4 dosage was much higher than we expected, her TSH levels was keeping at a very high level. She had thyroid function tested in two different hospitals. You see here the reference range of the TFT testings, but the result showing the similar result, and her TG level over 300 with the negative TG antibodies. And 3 months after radioiodine treatment, her TSH was 12, and then a diagnostic whole body scan was performed without stopping LT4. It showed lung metastatic lung uptakes, and there is also uptake here in the head. So therefore, a brain MRI was ordered. no significant abnormalities were detected. But here we noticed a suspicious pituitary hyperplasia. So we thought probably it's associated with persistently elevated TSH after surgery. So that was in 2018.
Hold on
So
just a
this
second.
patient,
Hold on just a second. Nicole?
Yeah, I was just wondering why in this we're thinking is a follicular thyroid cancer and it's NRAS driven, and we know they're very radioiodine and avid and good TG producer. Do you usually do a diagnostic whole body scan after you've given a high dose before and you
to be honest, that was before she came to our hospital, so we don't
okay.
know. They
Okay.
kind of
Yeah.
order this. Yeah,
Okay, thank you.
yeah, this all before our hospital.
Got it. Thanks.
Although one point is that if you already have administered the treatment, then it's worthwhile doing the post-therapy scans to see if your treatment is delivered. And with regard to that uptake in the skull, that you don't see the MRI correlate, I have experienced a few times when patients have this, and I go see them in the waiting room. Sometimes they are braiding their hair, and during that process it contaminates. So what I usually do is, if I see something, I usually tell them to do a thorough shower with lots of shampoo and then repeat the scan next day. And oftentimes that contamination goes away. So just a word of caution that, I mean, of course, this was done in another hospital, but sometimes you can avoid getting a brain MRI if you just have a repeat scan after washing the hair. But interestingly, here you're now finding a pituitary lesion on that MR.
Okay, let's keep going.
Right. So yeah. So because the patient complained about some cardiac symptoms, her TSH dose was decreased. Her TSH levels from 10, 11 to over 36 with low normal T3 and T4. TG kept as over 300. For preparing her the second radioiodine treatment, LT4 was stopped for 18 days. Her TSH reached over 100 and she felt okay. And here, before the radioiodine treatment, this patient was performed the whole body scan. And again, you can see here is another, uptake, so-called uptake in the brain, and another MRI was ordered. But I have to say, still, it's not in my hospital, but here they found no abnormalities again. But the patients was so worried about there may some problems in the brain, so she refused to do the second radioiodine treatment. And then we put LT4 again, and now you can see her TSH level still very high. And at this time, that's the first time she came to our hospital. We found over the past a couple of years, her TSH is still very high. And now we wonder what the reason for her refractory hypothyroidism.
All right, Dr. Busaidy, I know Dr. Urken is our resident expert on TSH and malabsorption, so we'll let him go second. But if you want to start, Naifa, what's going on with this TSH? And this can't be good in the setting of distant mets. So think through this a little bit for me, Naifa.
Yeah, so when patients come like this to me, there's a few things that we would have sort of warned this patient along the way, in that when their thyroglobulin was very high and they had lung nodules. We typically, when they have the lung nodules, we have that discussion with them that these may or may not be metastases, et cetera, until we see, we get the thyroglobulin, you're post-op, and then you have the radioactive iodine uptake. But I warn them that even if they don't have radioactive iodine uptake, these may be lung metastases and will be followed for life. The brain uptake, I love Dr. Ghesani's comment. It's very frequent, even if the patient came to me at this point, right? And I didn't have that, like in Dr. Guan's case. We want to talk about artifact. all the time. I think that's so key. And it's really nice that, in Dr. Ghesani's place, that in Mount Sinai, they actually make them shampoo and come back the next day, right? As opposed to assuming and just doing SPECT. So I thought that was cool. So I'm not answering your question, but I just wanted to comment. Now, in terms of the TSH, I think this is very fascinating, right? Typically, this happens more commonly in my 20-year-old patients, especially. I'm often asking them, did you take we all forget sometimes to take thyroid hormone. And then did you take more consistently right before coming to see me because you knew you were coming to see me? And I don't say it like that. I find a nice way to say it because they're young people who are not used to taking pills. Because typically when you see a high TSH with a normal T4, which is what Dr. Guan was showing us, it's very common because the TSH delays in normalizing and coming down. So it's very common that these patients are taking their thyroid hormone. Not taking their thyroid hormone or not compliant, and then later taking it, and you'll see the TSH slowly coming down. And you warn them that, listen, if I increase your thyroid hormone, I could make you clinically hyperthyroid, even though your TSH is not yet in the normal range because I'm giving you too much. So we want to be careful. I'm also telling them that when you have thyroid cancer, I want that TSH suppressed. It's like a chemo. And that when I suppress your TSH, your brain is saying, shut up. And I want that so it keeps the cancer down. So keeping a high TSH is not good. Let's do and try and find out what's going on. Now, having said that, it's very possible that they're very compliant, right? And there's other things going on.
That's awesome. Dr. Guan, you had a really nice slide. Walk us through your next slide to tell us what we need to think about in this sort of setting.
Yeah. So according to a very good consensus, so we try to find some problem with these patients, but we confirm the diagnosis and the lab results. We try different, assays, and we also excluded interference with TFT testings. And we asked about her compliance, and she confirmed the compliance. And we also try to find answers from her family, and her family members all told us, okay, she's a good patient. She took medications every day, and we check bottles and tablets in appropriate storage, and we review her thyroxine ingestion history, and we found that there is no other disorders and no other medications. And she reported no GI problems and medications, no lactose intolerance, and HP negative. And we also consider some increased turnover or excretion problems in this patient, but no. And the reverse T3 is low normal, suggesting her T3 levels kind of real low. But this patient refused to perform a thyroxine absorption test. So that's all kinds of adaptations. So we still do not have any answer for her refractory hypothyroidism.
That's amazing. We're going to move on to the second case, but just for the audience, can you just tell us, this lady, we stopped with her in 2019. What's happened in general in her case, just so the audience can get a picture here?
Right. So after she came to our hospital, so we gave her the second and the third and even the fourth radioiodine treatment. So in total, her radioiodine treatment was 700 millicurie. And after that, she still had a very high level of TG, and she progressed into bone metastasis, and she was enrolled in a clinical trial, RAS inhibitor clinical trial. Now she's still stable, but her TSH after the second radioiodine treatment, her TSH back to normal. Although it's not surprised, but back to normal. But her LT4, the dosage is still very high, higher than we expected. So still a refractory hypothyroidism, but luckily a little better TSH level. Okay.
Yeah, so not too surprising. I mean, we had early indications of high risk from the surgery, asking about that. We had Dr. Baloch being worried about high risk features of that. So that pattern, how pathology, and then it was a biochemical incomplete response and structural incomplete response. So a typical case there. Okay, let's move on to case number 2. Mark, go ahead.
Yeah, just one last quick thing on this slide there. The one thing I would add is get an expedited endocrinology consultation. Do not pass go. Do not try to figure this out. Once you get past compliance, you got to get them over to someone who knows what they're doing with thyroid hormone absorption here. There you go.
We agree completely. And when we put that consult in, we add have it done at a different institution. So yeah, we're completely on board. I tell people MD Anderson and NIH in Mexico City, world's experts at that. That's where they should go. All right, Dr. Guan, case number 2.
Okay, so the second case today is a 30-year-old female who is planning pregnancy. So in 2022, she had normal cell function, but elevated TPO antibody. Because now in China, you know, those patients, women who is going to get pregnancy, they will test their cell function and the TPO antibody. And because the TPO antibody positive, some doctors, they will prescribe ultrasound. Now we can see there is her ultrasound, a solid hypoechoic nodule in the upper left cell lobe, 1.2 centimeter, ill-defined margins no taller than Y shape with micro calcification. And you see multiple macro calcification involving an area of 2.3 centimeter. So F1A turns out to be a ALS, BRAF, V600E negative. So this is her photo of her ultrasound.
Dr. Baloch, remind me what AUS is. I never see nodules. Help me. This I'll come to Nicole and she'll figure this out for me. But what the heck is this in your guys' letter stuff?
So that's the part of the Bethesda classification for cytology FNA reporting, and it's called the middle category. So you have benign on one end, you have malignant on the other end. And in the middle, depending upon the nuclear features or cytology you see, including the background, it can range from what is called the atypia of undetermined significance. And the atypia can be cellular or other, which includes architecture. And then you can have follicular neoplasm, which looks like neoplasm or suspicious for malignancy. So AUS after benign, which is category 2, this is Bethesda category 3.
Awesome. Nicole, Dr. Guan's presenting this one to us in the setting of she wants to get pregnant. How does knowing that she wants to get pregnant in the near future sort of change how you deal with these nodules, Nicole, or does it change anything you do at all?
I mean, it would change only in the setting of an aggressive, probably an aggressive, if I'm thinking aggressive thyroid cancer. If not, I would just tell her to go ahead and get her pregnancy, and we can maybe study in parallel what's happening in the thyroid. But I wouldn't delay pregnancy.
Naifa, if this was a little bit smaller, I mean, the ATA guidelines are now talking about active surveillance for less than 1 centimeter as a rational upfront choice. If I made this 8 or 9 millimeters and suspicious, getting pregnant, not getting pregnant, are you using that to sort of change how you think about stuff?
Yeah, so this is it's very important to have shared decision making here with the patient so that they understand, right? And if the patient was 34, 35, versus 20, 30s there in between. So I think there's a few things that we have the discussion. So here you have a suspicious nodule, it's AUS. When we get that, we actually ask our cytopathologist to subtype nuclear versus non, just in terms of so that we understand risk of malignancy. And then we tell the patient the numbers. Let's say, in everybody's institution, my institution, it's 15 to 30%. But she's on the younger side, right? So it may be lower than that. And then, we tell this is the risk of cancer. But if we take, we talk about the options. If we took the worst case scenarios, how I presented to them, and this is a papillary thyroid cancer, well, that's not the worst case scenario, but typically if this turns out to be a cancer, then there are observational studies that have been done internationally as well as in the United States that have shown if you have a 2.5 centimeter papillary thyroid cancer or smaller, and it's a biopsy proven thyroid cancer, different from your case, then these patients were followed either by having it resect, surgery or observation with ultrasound. And what they ended up finding was that it was safe to watch these papillary thyroid cancers as long as there were no, lymph nodes. But in those who grew, they tended to be younger, right? It was those under 45 and the small percentage that it grew, which was the opposite of sort of what we were thinking would happen. And she's in that category. So we just need to watch her carefully. The second piece of data I would share with her is that during pregnancy in general, people who had biopsy proven papillary thyroid cancers, either residual disease or primary disease in place, that most of those patients, and there was retrospective data, the tumors did not grow during pregnancy, right? So even though we think that, 3/4 of papillary thyroid cancer patients are women, and we worry about estrogen, that's never been proven. And so that it may be safe. However, I also want to understand the timeline of the patient, right? Do they necessarily need to get pregnant now? Because I have them visit with my surgeon in terms where the location is of the tumor, what happens if it does grow, and how safe it would be if it does grow and you're in second trimester, right? So this would be a multidisciplinary discussion, my surgeon, the patient, their family, and, you could get pregnant post-op, right? I mean, we talk about a timeline post-op. So it's a bit of a nuanced discussion. Yeah, we don't spend as long as Mark Urken would spend with the patient.
Yeah, the length at times to get a consent for surgery. So, so clearly, most of the observational active monitors in the papillary frame, we're now starting to think about it in the AUS, the 3s and 4s, when the really smaller tumors, but much less data on that. So where did we go, Dr. Guan? I assume she went towards surgery.
Right. She went to surgery. She received a lobectomy and left central neck dissection because in China we kind of routinely do central neck dissection. And pathology indicates papillary cell cancer in the left lobe, and the lymph nodes metastasis shows up in 3 lymph nodes out of 10. And background is a Hashimoto's thyroiditis. But
Zubair,
this patient,
any high-level thoughts on this one, Zubair? We'll show you this one and then the next one. Yep.
Not much, but I'm trying to figure out that scattered calcification, fibrosis, background of Hashimoto's, and the AUS call with the BRAF negative. So one has to realize that not all papillary thyroid carcinomas are BRAF positive or BRAF mutated tumors, right? There are different versions of papillary thyroid carcinomas, and there are some which are associated with RET PTC and stuff. And as you know, that the RAS, BRAF, and RET, they are independent of each other. So you have to think about, and there are some subtypes of papillary carcinomas which will have scattered calcification. That means a lot of lymphatic permeation in the surrounding thyroid, fibrosis, and then foci of chronic lymphocytic thyroiditis. So, this is a chicken and egg kind of scenario. So is that due to the tumor infiltrating throughout the thyroid? So I'm not sure that scattered calcification and fibrosis was within the tumor or outside the tumor. And it being BRAF negative and the call being AUS, I have to also think of other subtypes of papillary thyroid carcinoma in this case.
Perfect. And let's show him the next slide. Get a little close-up picture here.
Yep.
Yeah.
There you go.
So the patient came to our hospital for the second opinion and also for consultant because she's going to pregnant. So the second opinion turns out, yes, this is a different subtype, papillary cell cancer. And the gene panel showed it's a RET rearrangement papillary cell cancer.
Okay, Zubair, tell us about this.
So this is, you can see in those spots, in the figures, you can see the most right one has some of those dark areas are somomatous calcifications, and they look, the radiologists who are very proficient in doing thyroid ultrasound will tell you this looks like almost like has that kind of, I always say it has that snowstorm pattern because it has a lot of echogenic foci. I mean, it's very common in the younger age group because this is one of those fusion-associated carcinomas. So you have and this is the most common RET PTC arrangement that you see in diffuse sclerosing subtype. It is an aggressive tumor, and it will have multiple lymph node metastasis as well as pulmonary and other stuff. But this is a typical picture of this tumor.
Naifa, help me out here. I mean, I'm a little puzzled because most of the time, if it turns out to be a diffuse sclerosing, we've got changes on both sides, and I don't remember the last time I saw a lobectomy for diffuse sclerosing. So can help me sort of think through this, and we're gonna have to think about, do we need more surgery? What's going on here?
Yeah, this was very interesting. So, as Mike and Zubair mentioned, that when you have diffuse sclerosing variant, this is typically a pediatric thyroid cancer or younger patients, and it can look very angry to the surgeons, and it can look like Hashimoto's, like Zubair was mentioning, but it's typically bilateral, it's typically in lymph nodes, it's typically with lymphovascular invasion. And so this is interesting that here you have the lymphovascular invasion, but the other side looked okay, I'm assuming. I mean, I would have talked to my surgeon, but I think that's what was mentioned. And you have, a couple of central lymph nodes, right? So if you take a 30-year-old, you're typically telling them that you've probably had this cancer for a while. It's, it's cancer from when you were much younger. But it's just interesting if it's only, if it's only on one side and with lymph nodes, and your ultrasound looked completely normal on the other side, you could make an argument not to do a completion. It's just an unusual, usually the surgeon's in there and they're like, this is angry, I'm removing the whole thing, right? Yeah. I don't know. If I would, I guess I would, she's 30 years old and she wants to get pregnant. So I guess I might make her wait a couple of months and check a thyroglobulin and just see, and image her, help decide that. Because the ret doesn't bug me. I think like Zubair said, it fits. I'm not sure.
Yeah, Mark, help me out. I mean, I'm a low volume surgeon, so help me out in terms of what you're finding in there, what you're thinking here, Mark.
Yeah, make that a very low volume surgeon. Extremely.
It just says less than 50. Less than 50.
Extremely low volume. But yeah, I mean, if we want to, I would argue if we want to go down the rabbit hole of the current ATA risk of recurrence, this fits into intermediate to high by virtue of aggressive histology and that greater than 2 millimeter lymph node, not 1.9, but more than 2 millimeters. So, as I was thinking about this case, I mean, the only question is kind of that checkered history of whether or not this would concentrate, take up RAI, and that might influence. But I think in most of our minds, given this finding, we would argue for a completion thyroidectomy. And I think your intraoperative concerns are correct, that what we were talking about in terms of what this feels like, what it looks like, would probably have pushed towards, as long as you had consent, doing a completion at the time.
Munir, Mark touched on this concept of, if we're thinking about completion, we want to know what's the likelihood that radioactive iodine would work, right? So if I called you up and said, in a diffuse sclerosing, is this one likely to be RAI avid, RAI resistant, somewhere in the middle? You've been doing this for a couple of years. What do you think, Munir?
So there are a couple of studies that have looked at the percentage of uptake in the diffuse sclerosing variant. In general, about 80% of papillary thyroid carcinoma are extremely avid for iodine, the classic one. As opposed to that, the diffuse sclerosing variant has only about 38% likelihood. So it's not all or none, but Mark is correct that in general, they have lower degree of uptake, and in general, a larger percentage of diffuse sclerosing variant will not have radioiodine uptake. So that does impact on the post-surgical management.
Yeah, and that's what we often see, that even when their diagnostic scans are usually negative, their post-therapy scan is positive about a third of the time, and even then you don't always get a great response. I mean, I think they're getting less lesional stuff. So I would say on this one, this one's a weird one, right? Because we don't generally see diffuse sclerosing presenting in this direction. So if she was really chill, I love Naifa's. I often ask them to wait 6 months. Hey, I don't believe she doesn't have more lymph nodes in there. I bet she's going to have thyroglobulin antibodies. This story is going to play out over a little bit. So if she can wait with me for a few months, we'd probably start with waiting. So what did you guys do?
Yeah, Actually, we were asking the same questions. Should the completion thyroidectomy performed? And if the second surgery needed, what's the optimal timing? And we try to discuss with this patient. And this patient, she decided to wait and see. And we gave her LT4, keeping her TSH level around 0.1, 6 months after surgery, no signs of recurrence. And she got pregnancy 9 months after surgery. TSH was good. However, she had to terminate the pregnancy at week 11. After that, her TSH level was fine, no recurrence. And in October, that should be, that part is all okay. But in October of 2013, after COVID infection, she felt palpitation, right thyroid lobe enlargement, and TSH below the normal range with slightly elevated FT3 and FT4. And we stopped LT4 for 2 months, and we rechecked her TSH, FT3, and FT4, and TRAb level was also elevated. Turns out her thyroid now occurred Graves' hyperthyroidism. We treat her with methimazole, and in March 2024, her TSH is normal and TRAb level still high, considering she's going to pregnant in the near future. So we again recommend surgery this time. And this time, this patient agreed to have surgery. Now she had completion thyroidectomy plus central neck dissection, the right side. And the pathology turns out to be autoimmune thyroiditis, no lymph nodes metastasis. These are pathology slides here.
Zubair, help me here. I would have bet you most of my, well, I don't have anything, that there would have been diffuse sclerosing on the other side. I mean, what's going on here, Zubair?
So, the more you see these, and I'll tell you that I always, classically, we always thought, and in most cases, it's a bilateral disease, multiple lymph nodes. But if you look at the umbrella, if you take the molecular profile as an umbrella, red PTC arrangement with CCD6, and you're looking at that, you see different spectrums of those. I have seen these tumors, which the nidus of the tumor, which can be smaller or larger, is the classic papillary thyroid carcinoma, and then it spreads out at the periphery like a diffuse sclerosing subtype. And that can be involving of just one lobe, and the rest of the lobe is normal. So I think we have to realize as more we see these tumors from the pathology and clinical point of view, that there's a whole spectrum of representation. So that's why I sometimes say that the main tumor is classic papillary, but the infiltration pattern is of diffuse sclerosing subtype. So there are these tumors where we use the term features of. And some of these tumors are unilateral. We see them in pediatric age group as well as in the adult age group. So not all of these. So if you think from that umbrella of the red PTC arrangements of that, you may see different versions of morphology and presentation.
And do you think we've just caught this one early in the natural history of this disease, and it would have eventually?
I think so. I think that's what it is. Yeah. But I think it fits into that profile of that tumor, the molecular profile.
That's fascinating. Dr. Guan, let's go ahead.
Yeah, so we discussed with her the option of radioiodine treatment, and she hoped to conceive in the next 6 to 1 year. So no radioiodine was given. Her TSH suppression was good. And post the second 6 months post the second surgery, no recurrence on ultrasound. TG antibody decreased significantly, and TG level is low. And she got pregnant in December. And during the whole trimester, we kind of repeat her ultrasound and showed no recurrence. And just 2 weeks ago, she gave a baby, healthy baby. So now she's good. Yeah, she's very good. She's no recurrence. I'm going to see her in about 3 weeks.
Always nice to have a happy ending on a second case of a tumor board. Last thoughts about this before we touch on the third one?
No, it makes our hearts warm. And I think it's important to keep in mind, right? So I would have gone back to Zubair, exactly like Zubair said, right? When you saw that pathology and then, you go back and read, I mean, how did this even happen, right? How did she get Graves afterwards in the other side, right? And did the the immune system went up postpartum, but it was a very nice case, Dr. Guan. I don't have any comments.
Yeah.
That's awesome.
Yeah, I'm also very happy she had a baby now.
That's what she started out to be, right? That's the story of her life. We get all hung up in the cancer, and she wanted to have a baby. And outside of our clinic, that was the most important thing, which is awesome. Okay, let's start. We can do a few minutes of case 3. Let's look at case 3.
Right. The case 3 also another young woman who is going to be pregnant, but this patient has a past history of diagnosed Graves' disease and starting methimazole and then stop methimazole with totally normal TFT. But before planning pregnancy, she was ordered ultrasound. Again, the ultrasound showed a high risk nodule. So one on the left side. So this left side turns out to a TR5, and the right side turns to a TR4 nodule. So these 2 nodules photos here. Okay, so FNA was performed. Right nodule turns out to the Bethesda 3 AUS NRAS positive, and the right nodule turns out to be a Bethesda 5 PTC and BRAF positive. So that's
Zubair,
the 2 nodules.
Zubair, help me understand what I'm looking at there, Zubair, since we got some nice pictures here.
So, I mean, I'm just looking at from those pictures. So the top panel shows you, as you can see, the bottom panel and the top panel, even the bottom panel is on high power. You can see a lot of cells in the bottom panel. So, and as compared to less cellularity on the top. But you can see the top right panel has a lot of cells which are caught up in the clot. This is actually a very typical low power presentation where you see the tumors when you are into that intermediate categories. The bottom panel, I mean, it's really, you can see these are like finger-like projections or finger-like structures. So this is a classic subtype of papillary thyroid carcinoma. So the Bethesda 6 at the bottom and Bethesda 3 at the top, even though those are low power. So that's what looks like it.
Perfect. Okay, Dr. Guan, let's go ahead.
Okay, so in August, this patient received a near total thyroidectomy, so the total left lobe and near total right lobe, because the right lobe, they thought probably it's just a neoplasma, RAS mutation one, and the central neck dissection, and the intraoperative findings, no gross ETE, and the frozen section pathology turns out left lobe as a PTC and right lobe as a follicular neoplasma. Okay, so there is the pathology, post-operative pathology. Right thyroid, follicular thyroid carcinoma, minimally invasive type. But there is another incidental papillary thyroid cancer. So this one, we didn't find out on ultrasound before the surgery. And the left lobe is a papillary thyroid carcinoma, classical type, and tumor size is only 7 millimeter. And lymph nodes, we found 3 lymph nodes metastases, but all very small lymph nodes metastasis. So this patient's now diagnosis is right follicular carcinoma, minimally invasive type, NRAS positive, and lateral papillary thyroid carcinoma, classical type. On the left side, the papillary thyroid cancer is a BRAF positive, staging 1 low risk differentiated thyroid cancer. Now she's on LT4 75 microgram per day, and her TSH goal is 0.5 to 2.0 as she is going to plan pregnancy. And we plan to monitor her TSH thyroid function every 3 to 6 months. Ultrasound is planned at 6 months after surgery, also because she's going to pregnancy. So
Let me pause there for just a second. Zubair, since we've been talking pathology all morning, this minimally invasive term has sort of evolved over the last several years. What do we mean by that now?
So minimal invasion means it's invasion in the capsule of the tumor. Some pathologists believe that it has to go throughout the entire capsule into the surrounding thyroid to be called as capsular invasion. I personally think that when it invades into the capsule, to me, that's an harbinger of something else going on in this tumor. So I will make sure that I exclude angio invasion. Europeans do not call these carcinomas. They use the term of follicular tumor of uncertain malignant potential, a kind of a mouthful. But I think basically what we have to realize that even if we say minimally invasive carcinomas, majority of those are going to act like follicular adenomas as long as the capsule of the tumor is entirely sampled to make sure that we have excluded vascular invasion, which is more important.
That's beautiful. We got about 3 minutes. Nicole, give me 1 minute on where you want the TSH goals, and Naifa, if we're not doing radioactive iodine, how do we do follow-up? Nicole?
Yeah, I would think I would keep the TSH in the low normal range, since I think it's a low risk tumor. Everything she got resected.
Beautiful. Naifa, real follow-up on somebody like this? How do you really do it in practice?
Yeah. So real quick though, these patients take a long time, even though she's clinically going to do better than the first case, because she's like, how do I have 2 different cancers? Right? Like, how did this even happen? And now I'm going to cancer all over my body. Anyway, that's not what you asked. I apologize. I have to put my comments in. So in terms of follow-up, the total thyroidectomy was not wrong to do, even in someone who wanted to get pregnant, because she had Graves' disease to begin with. So you're treating both diseases. So even though she went into remission, postpartum, she may have gone back. So now that she's had the total thyroidectomy, you're going to do the ultrasound at 6 months, and you're going to check the thyroglobulin antibody. And we do ultrasounds, even though follicular thyroid cancers don't really usually come back in the neck, but she had the papilla that went to lymph nodes. So ultrasound the neck, TG, I do 6 months times 2, and then once a year.
Dr. Ghesani, I got 2 minutes left here. From the nuclear medicine standpoint, where are you guys with radioactive iodine in terms of low risk, low intermediate, high, sort of at the 30,000 foot view? How do you think about that, Munir?
I think for the low risk in this case, there's really no indication for routine imaging, whether it's iodine scan or FDG PET. I think it should be primarily driven by any suspicious finding on ultrasound or the bump in the thyroglobulin values.
Beautiful. Fantastic. Mark?
Yeah, last point here. So this patient underwent a near total thyroidectomy. So I think it just depends here kind of how much of a remnant there is left as to kind of what your value of thyroglobulin is going to be and how well that's going to be an indicator. So I think the devil's in the details on that.
And I think that's why that's really important for you guys to put that in the I know it's sort of banished in the United States. Nobody admits they really do that. But if you really say we left a little either to protect the nerve on one side, because the other, that helps me interpret the post-op thyroglobulin, helps me interpret the post-op ultrasound, right? So being transparent and clear, and Mark and I have talked a lot about this, how do we get that information from the operating room transferred to the pathologist and to the endocrinologist? That's an important piece of information to know, because the TG could easily come back at 3, 4, 5 instead of 1, and we would be fine with that. So Dr. Guan, you put together the most amazing cases. You win the prize this year for beautiful cases. Dr. Baloch made me very happy with lots of stuff for him to look at. So thank you, and thank you all for the panelists. You did a wonderful job again, and we'll see everybody back at the next one.